Hi, everybody. I'm Diane O'Leary, and today I'm going to talk to you about an ethics-based approach to clinical care for ME and Long COVID. So let me just share my screen with you. I'm going to cover an awful lot of material in a short period of time today, so I'll just dive right in. First thing I need to say is thank you to the Op-Ed Project and Equality Now for supporting my work. This year, I'm a Public Voices Fellow on advancing the rights of women and girls, particularly for my work on medical gaslighting and gender bias. Okay, so today the structure of my talk is really pretty simple. In the first part, I'm going to talk about the status quo, where things stand in clinical care for ME and Long COVID. Then I'm going to shift and talk about what it would mean to base care on ethics instead. And finally, at the very end, I'm going to apply some of the concepts that I've raised to talk about how patients respond to the problems with clinical care. Before I dive in, I do want to say some things about ethics in general. People often think, well, what's the point of medical ethics? It's a good question, really. The idea is that people with disease are vulnerable, unusually vulnerable, and that makes doctors unusually powerful. So medical ethics makes sure that this power imbalance doesn't lead to problems with clinical practice or disrespect of patients as persons or threatening patient dignity or diminishing human rights. These are basically the goals of medical ethics. People often say, well, yeah, but doesn't an ethicist just say what they think is ethically right and wrong? And who cares? How is any of that enforceable? The big principles of medical ethics actually do dictate how medicine is practiced. When I say big principles, I mean the big overarching ideas that have been firmly established in medicine for a long, long time. There's a lot of little ideas that don't have that much impact, but the big principles actually affect how medical care is practiced. For example, everybody has a right to informed consent. That's an ethical idea. And doctors, nurses, policymakers, clerical workers, administrators, everybody in the healthcare system has a role to play in making sure that every patient does give informed consent to their care. So that ethical idea is built into medical infrastructure. Health professionals just don't have the option of refusing to abide by the big principles of medical ethics. And these really are enforced by laws and human rights and professional codes. So when I say that ethics principles, the big principles of ethics, dictate standards for good clinical practice, I'm not saying, hey, here's what I think should happen. I'm saying that this is an enforceable set of standards. If it's true that basic medical standards demand that practice should happen this way, that's not just a good idea. That's actually an enforceable idea. Okay, so part one, I want to talk about the basic status quo in clinical care for ME and Long COVID. Where are we at right now by default? Usually with everyday disease, with conditions that are not contested, science tells doctors what to do. So scientists establish best practices for diagnosis, for treatment, even for how to talk to patients. And these principles are refined and further refined, and there are challenges, and you refine again. And through this process, you develop practice standards that determine what it means to provide good care for a given condition. For ME and Long COVID, of course, there is abundant evidence in scientific research of biological disease. There isn't any question, really, that the evidence for biological disease far, far outweighs the evidence for psychological causes. But we do still have research, conferences, treatment centers, doctors who insist that these conditions are primarily psych. So as a result, we really don't have practice standards for ME and Long COVID the way that we do for better understood conditions. There are some practice standards for ME in the UK and in the CDC in the US that are pretty firm, but these are actually not enforced, and they don't really make their way into medical education. So they're, even when the standards exist, they're not handled in the way that practice standards usually are. So the difficulty with this, of course, is that doctors still have to do something with the patient in the room, right? So when science doesn't tell doctors what to do, what are they supposed to do? How should we be handling that problem? The current approach that we're taking is a clinical free-for-all. I think of it as mayhem. I don't know if people in Europe have this guy in TV commercials. In the US, this guy is mayhem in insurance commercials. What's going on now in clinical practice with ME and long COVID is basically every doctor decides for herself what she thinks the right approach is, what she thinks the right treatment is, how she should talk to patients. It's pretty much a total free-for-all. The best way to see that is to look at how one long COVID patient is handled differently by 3 doctors. So let's say the first doctor tells the patient that she's got a disease. Doctor orders tests, prescribes trial treatments, arranges a consult with the dysautonomia clinic. The second doctor, same patient, tells the patient the problem is psychological. She orders no tests, prescribes no treatment, and arranges a consult with psychiatry. A third doctor might believe that the problem is psychological, but she's going to hide that truth so that the patient won't reject the treatment she needs. So this doctor tells the patient that she's got a functional brain disorder, and then convinces the patient that physiotherapy for faulty illness beliefs is actually physiotherapy for brain disease, and then the patient willingly participates. Obviously, you get all these options and many more with ME, and these have been going on with ME for a long, long time. We might think that since we have no specific practice standards, we don't have any choice but to have this kind of clinical free-for-all, but that is really not the case. So it's important to step back and think about why this free-for-all approach is bad medicine. The primary concern there is that doctors don't actually have a mission or the resources to do research that can resolve scientific debates. That's no different for ME and long COVID than it is for any other condition. Doctors are not the people who figure out the nature of people's conditions. When we leave it up to each doctor to decide on management for herself with no requirements for informedness, most of them are going to decide in the easiest possible way, because that's just human nature. That's what we all do when we have the freedom to do things as we like. As a result of that unending freedom, care for ME and long COVID is often based on hunches or personal biases or professional loyalties, or on the loudest voices that the doctor happens to have heard in the media. It's helpful, I think, to step back and look at how uncertainty is handled in a different area of medicine outside the context of contested conditions. So let's imagine a scenario where there's a patient who has a potentially deadly form of cancer. There are 3 treatment options available. All of them carry very big risks. What happens when there's this kind of uncertainty in treatment? Is it up to the doctor to decide which of these is best? Well, not really, because again, doctors are not researchers. So they are really not the people who are set up to resolve the question of which treatment approach is the best one. Doctors do have to provide care, so really, isn't it up to them? Not really. Again, doctors do choose the treatments that they're comfortable with, and no doctor is obligated to provide a treatment that she thinks is unsafe or that she feels she can't do well. But doctors' choice of treatments or choice of management is not the end of the story. The difference in the cancer scenario is that the oncologist stays aware that her choice might be mistaken. So that possibility of error and the effort to avoid harm, the effort to avoid risk, guides everything she does with the patient. In the end of the day, the most prominent difference between the cancer scenario and what we've got going on in mayhem with ME and long COVID is truth telling. In the cancer scenario, the doctor understands that she's got to tell the patient about all the treatment options with their risks and benefits. When she does that, she explains the reasons why she offers her treatment of choice, and then she lets the patient decide with an offer to refer to alternative treatments. All righty, now that we know where things stand and what it looks like in another area of medicine, it's quite different. Let's think about how ethics might help determine how practice should go with ME and long COVID, given that we don't have scientific standards. When science doesn't guide practice, we can rely on ethical standards. And really what I'm going to offer here are basic defining principles for medical practice that are utterly uncontroversial and entirely universal. The reason that these are ethical principles is because these are such basic defining principles for doctors' work that it is an act of injustice to give them only to some patients and not others. So these become ethical principles when the normal standards that leads doctors to abide by them are abandoned. So, okay, two fundamental questions to ask when we talk about ethical standards for practice with contested conditions. First, what do doctors have to do? What actions are doctors ethically obligated to undertake? And second, what do they have to not do? What actions are they obligated to avoid so that, you know, whatever else you do, just make sure you don't do such and so. There are three kinds of actions that doctors are obligated to undertake. Obviously, doctors are obligated to undertake a whole pile of other actions besides these three, but these three are the most relevant to the question of how to handle ME and long COVID. The first one is the duty to be informed. The second, the duty to err on the side of biomedical caution. And the third, the duty to provide biomedical care to every person who seeks it and has a need for it. So I'll go through these pretty quickly. The first one is the most obvious. There's a duty every doctor has to be informed to a certain minimal standard. And by that, I don't mean, you know, reading social media. I mean, obviously, you have to be scientifically informed. Without scientific knowledge, medicine is not medicine. It's just guessing. I don't think the current failure to be informed is the fault of doctors. I have a talk, I gave a talk a couple months ago for the ME Association in Norway, where I talked about failure in the link between the science and the doctors. So I really think the problem is a breakdown in that connection, but it doesn't make any difference. Doctors still have a duty to be informed, and it's an ethical problem in every case when they're not. Second, doctors have a duty to err on the side of biomedical caution, to keep risk in mind. There's some complexity to this because obviously doctors do also provide mental health care and social support and all that kind of thing. But there's a lot of other providers in the system who do those things. There's nobody else who does what doctors do, right? The buck stops here when it comes to diagnosis and treatment of disease, when it comes to harms caused by disease. So when you don't have practice standards, erring on the side of biomedical caution means, if nothing else, it means remaining aware that disease is possible. In ME and long COVID, when you're informed, you know that there's a pile of biomedical research that says there's disease there that's harmful, potentially very, very dangerous. If you don't keep that possibility in view, even if you think the problem is psychological, if you don't keep that possibility in view, you're not erring on the side of biomedical caution, and you do need to keep it in view, not only in practice, but in discussions with patients and in the patient's record. Third, and this is probably the most basic principle that there is about what doctors ought to be doing, doctors have a duty to provide biomedical care to every patient who seeks it, who has a need for it. That very basic duty gets really complicated, though, without practice standards. It's impossible to stipulate what the standard of care is when you don't actually have it written down somewhere as a matter of practice standards. So at this time, difficult as it is, doctors actually do not have an ethical duty to provide biomedical care to patients with ME and long COVID. They do have a duty to be informed about the science. They do have a duty to keep the possibility of disease in view always, but they do not have a duty to provide biomedical care. On actions that doctors are obligated to avoid, there are two: the duty to avoid bias and the duty to avoid blocking access to medical care for patients who need it. The duty to avoid bias is everywhere in medicine. Obviously, doctors are always trying to overcome cognitive biases that get in the way of objective reasoning, because objective reasoning is what keeps patients safe, right? In ME and long COVID care, this is particularly important because debate about ME and long COVID has been politicized, not just between patients and doctors, and not just in the public arena, but within the profession. There are factions, some say biological disease, some say psych. So often decision-making is based on factions and loyalties. Obviously, this isn't good for anybody. No patient care should be based on this kind of thing. The duty to avoid bias has to be consistent. Finally, the duty to avoid blocking access to medical care is probably the most important one out of the 5 that I've raised. When practice standards are lacking, this one is really as important as it gets. The fact is that doctors are not always obligated to provide biomedical care to the patient in front of them. Let's say, for example, you go to your doctor for a sinus infection, but the doctor has a stomach virus. You can say, sorry, I can't help you, right? Or let's say you need a certain procedure. You go to a doctor, you say, I need this procedure. The doctor can say, sorry, I don't do that procedure. I don't think it's a good idea. Doctors can do these kind of things, but when they do, they are required to inform patients about the possibility that they do need the biomedical care that hasn't been provided, and they have to facilitate access to that care with a referral. They can't just close the door to medical care when patients might have a disease that requires medical care. In the end of the day, then, ethics requires that clinical practice for ME and long COVID will be scientifically informed, keeping the possibility of disease in view. It will inform the patient about both approaches, presenting the science on both sides, acknowledging that the science favors the biological side, which it unequivocally does, presenting treatment options on both sides, and explaining the doctor's approach with an offer to refer. This is how it works in every other area of medicine. For some reason, with ME and long COVID, these fundamental principles that define medical practice are set aside. Some will object to this approach, suggesting that if you do things this way, nobody with psychosomatic symptoms will ever get treatment. Treatment requires the patient to have an understanding that the problem that they have is small and can be reversed. So doctors' attitudes play a really big role in successful treatment for psychosomatic symptoms. On top of that, if you give patients with psychosomatic symptoms a choice between biomedical and mental health care, they'll never choose the mental health care. These things are true. The only way to treat psychosomatic conditions on the current model is for the doctor to not be neutral and not be truthful, but to project a total sense of confidence in the treatment approach that she's adopted for psychosomatic symptoms. All of these things may be true given the way that psychosomatic symptoms are currently treated, but they violate the duty to be informed about disease, to keep disease in mind, to avoid bias. Most importantly, this approach violates the rule of avoiding closing the door to biomedical care for any patient who might have a need. More importantly, the general approach of just presenting the psychosomatic side and presenting it without keeping disease in mind, this approach is not truthful. And truth-telling is the cornerstone of medical ethics. To emphasize that, here's a quote by Simon Wesley from a paper in 1999 called "To Tell or Not to Tell," where he really is directly discussing whether doctors should tell the truth to patients who have psychosomatic conditions. "Is it all in my mind, doctor?" says the patient threateningly. The correct answer from the truth-telling doctor will be yes, followed by, "But psychiatric disorders really are genuine illnesses." But by that time, the doctor will be addressing an empty room, since the patient might well have left in disgust. This is really the foundation for management of psychosomatic symptoms now, 25 years later. The idea is that you can't do not tell the truth, because if you do, patients don't get the care they need. You have an obligation to give them the care they need, so you have to compromise the truth. Second, patients have a right to give informed consent to care. But when you don't tell them the truth, they're not informed, and that actually invalidates informed consent. The only time that you can waive informed consent in medicine is when patients lack decision-making capacity, and there just isn't any evidence that patients with ME and long COVID lack decision-making capacity. So this one is hard and fast rule. Finally, there's an ethical requirement to respect patients' autonomy. Truth-telling and informed consent are really just reflections of doctors' respect for patients' autonomy. In medical ethics, this idea of respect arises from awareness that every patient is a person, every person matters, and every person has a right to make her own medical decisions. When doctors withhold the truth and fail to inform, those are unequivocal acts of disrespect, and there is no room for that in standard ethical practice, in standard clinical practice. So it might seem compelling that if the only way to get the patient treatment is to violate respect for autonomy, well, then you ought to do it. But really, that idea has gone round and round a million times, and there just isn't any room for that kind of thing. The fact that the doctor wants a certain kind of treatment to happen does not provide a basis for denying patients respect for their autonomy. So you see here where we end up, the difference between the free-for-all, where doctors do what they like, favor the side they like, offer only their favorite treatment, and where you land when you just adhere to the defining principles of medicine as they're understood to apply to all patients equally. Doctors' decisions are neutrally guided by science. They learn both sides. They present both sides. They err on the side of biological caution. They explain all the treatment options. And when they don't offer the one the patient wants, they refer. This is basically the difference between them. I think it's important to acknowledge that there certainly wouldn't be any ethicists in the world who would think that the current free-for-all is a better idea than the ethics-driven approach. But also, there probably aren't many outside of ME and long COVID, there probably aren't any clinicians in the world who would think that the stuff on the left is a better idea than the stuff on the right. These things are just uncontroversial, absolutely firm principles for practicing medicine. So the fact that we're not doing it this way is very strange. In the end of the day, in the absence of science-based practice standards, Ethics gives you all that you need. You can work out what it looks like to provide good clinical care for ME and long COVID in the absence of scientific standards, just by paying attention to the basic standards for ethical practice. Okay, to finish up, I've said an awful lot of things here about ethics, different ethical concepts, how they're enforced, what they mean. And I would just like to try and apply these a little bit to the way that patients understand the shortcomings of their clinical care and the way that patients respond to it. People with ME and long COVID obviously are frustrated with the current status quo in medical care. It's important to recognize, though, that this frustration is not just about clinical failures. It's not just, well, my doctor didn't do these practical things that doctors should do. The feeling that people have when patients see that clinical care is this free-for-all, right? The feeling that patients have about that is really, I think, best described as moral outrage. It's not just, you didn't do the right science stuff. It's, this is not how medicine should go, morally speaking, maybe as a matter of human rights. I just would like to validate that this intuition is absolutely correct, but not for the reason that patients often think it's correct. People with ME and long COVID have the experience of a serious disease, great deal of suffering, great deal of harm. And it's natural to conclude then that I have a right to medical care. I have a disease. I have a right to biomedical care. Though I believe you do have a disease. I'm not a scientist. I can't really comment on that, but it sure looks like the science says that you do. That's really not the reason why medical care for ME and long COVID is off the rails. The reason is because the moral standards for medical practice in every other area of medicine are not protected for ME patients and long COVID patients. The rights that patients have in other areas of medicine, they don't have here. The right to the truth, the right to informed consent, the right to respect for autonomy. For some reason, when it comes to contested conditions, medicine lets go of all of these rights and basic ethical principles. That is the reason why you feel moral outrage and the reason why you should. Every patient has rights. The question that you're asking when you're grappling with this outrage about your care is, why are ethical principles violated in care for ME and long COVID? Why are my rights as a patient violated? Very sorry to say that I cannot answer those questions. I don't know why. I just would like to direct you to the idea that the problem with your care isn't just about science. The problem is that there are ethical violations happening in your care every day. In the end of the day, really, the idea is this: when you protect resources and rights for most people, but you single out some little group and they don't get the same resources and rights, well, that's an act of injustice. Now, in the end of the day, I think what I'm suggesting is that clinical practice with ME and long COVID isn't just a matter of science, it's also a matter of justice, because basic standards, basic rights are routinely violated here just for these patient groups, just for patients with contested conditions. When the science fixes care for long COVID and ME, when we do have practice standards, that's not going to fix the justice problem. It will for ME and long COVID, but other patients with contested conditions, with Lyme or EDS, patients with rare disease that's not diagnosed, patients with endometriosis, they're still going to face this problem of social justice. So that, I think, is the bigger question that needs to be addressed. Okay, that's it for me today. Thank you so much for having me. I am always happy to hear from anybody who wants to talk about these issues. That's my email right there. You can also find my contact information at my website, dianeoleary.com. Thank you. Take care.